Good morning, how are you? My name is Shireen Atabaki. I am an attending physician in the Division of Emergency Medicine at Children's National Medical Center here in Washington, D.C. It's nice to see so many faces that I recognize. Great to see you all. And there is going to be maybe a little bit of overlap between Jerry's talk and some of the things I'm going to say today, but I'm going to focus mostly on outpatient emergency department and acute care of children. Obviously, no financial or other conflicts of interest to disclose slide goes there. And so the objectives today are first to familiarize you with the epidemiology of blunt head trauma and talk to you a little bit about the radiation risks associated with CT scan. How many of you have heard things in the media recently about radiation risks of CT scan? So pretty much the majority here. Do you think there's a rise? Have you seen an increase nationally in the media exposure? Well, good. I'm going to talk a little bit about how that's played out. And then I'm going to talk to you about the Pediatric Emergency Care Applied Research Network, which I'm a part of, that created the prediction rules for pediatric blunt head trauma and cranial CT. And then I'm going to talk about mild traumatic brain injury research, fresh off the press, to update you, and it'll be hopefully relevant to your practice. I've picked some items of studies that we've done and others have done that should be relevant to your practice in helping manage this problem. So the epidemiology, the most frequent diagnosis in an injured child is head injury. And every 11 minutes, one child in this country has a brain injury that results in some kind of permanent disability. And football is the #1 associated sport. However, there are many other sports. And one of the top sports in girls, anybody have any ideas? Cheerleading, yeah, very common. And half of winter sports injuries actually end up having some kind of associated head injury. So these are very gross estimates, and we don't really know the numbers because the data is not necessarily coming in. A lot of children are seen in the primary care setting, or they are screened by primary care physicians over the phone. And the estimate is there are about 5 million children with head injuries annually in this country, which is a lot. And we're talking, 0 to 18 years of age, so a large population of kids. So what is the first question that folks here might ask when you get a call from the mother of the 6-month-old that fell off the couch? What's the first question you ask them? Did they cry immediately? That's a great question. And, that's the question we asked to determine if there was loss of consciousness or not, which has been an important risk factor for us historically. There are about 600,000 emergency department visits, and this is from the National Center for Health Statistics annually in this country, again, for traumatic brain injury or blunt head trauma. And about 90%, estimates now are that it's much higher than 90%, actually have mild traumatic brain injury, which is a Glasgow Coma score of 14 or 15. Obviously, the Glasgow Coma score is a pretty rough estimate, a rough tool to measure mild traumatic brain injury, and we have some better tools now, such as the Acute Concussion Evaluation that Jerry developed. And current emergency provider and primary care provider practice in some ways, acutely, emphasizes the decision for cranial CT. So the reason we ask the question, did you cry or not, is often to decide whether or not to refer the child for imaging, for emergent imaging. And the majority of children with mild traumatic brain injury actually end up being sent home from the emergency department. And I'll tell you a little bit about what happens to them when they go there. So what do we worry about? Well, we worry about second impact syndrome. And probably, it's a very, very rare syndrome and probably not the most likely thing, but it's what we worry about. It's what we hear about in the press. This is diffuse axonal injury resulting from a second concussion. How many here in the room familiar with second impact syndrome? So a few case series from professional athletes, usually younger age, where they had a first concussion, returned to sport, or a first mild traumatic brain injury, returned to play or sport while still symptomatic, and had possibly a mild second impact and developed this diffuse axonal injury, herniated, and died. But if you look at the literature, very few cases, about maybe 20 cases over a 30-year period, and all the circumstances are not the same. So the other thing that we worry about is intracranial bleeding or intracranial hemorrhage. We worry about epidural bleeds, subarachnoid hemorrhages, cerebral contusions, interventricular hematomas, and intraparenchymal bleeds, many other things that can be detected with CT scan. And now we're going to worry about their management and concussion. So CT scanning is a great tool to rule some of these things out, intracranial bleed. And non-contrast head CT has been around since the 1970s. And we have newer imaging modalities that are more rapid with helical CT scans and can rapidly get a CT scan without contrast that would be able to identify bleeding in the head. And here's a child with an intracranial hematoma and a midline shift. And this is really what you worry about. This is what you wanted to rule out with your CT scan. We all know what to do with a child with significant head injury, right? This is something like from Grey's Anatomy where the woman who's the cleaning lady is actually a neurosurgeon and she ends up saving the life of the patient in the hallway. So we know what to do. We know what to do with this child with significant injury. The question is, what do you do with the 13-year-old who's on the soccer field playing sports, gets a head-to-head impact with another player, has a couple of seconds possibly of loss of consciousness, is then dizzy, has a headache, and you're acutely seeing him in the emergency department. Or they're calling you on the phone and they want to know what to do. So how many of you would send this child to the emergency department for a cranial CT, with that recommendation? Nobody in the room? So I have had some referrals. So he did have loss of consciousness for about 5 seconds, and now he's got a severe headache, and he's had 2 episodes of vomiting. How many of you would now send him for evaluation for cranial CT? Okay. What changed it for you, doctor? The vomiting, okay. And that's from data from Ann Dietrich from about a decade ago, where she recommended from a very small series of patients that 2 or more episodes of vomiting put one at a higher risk for intracranial injury. It was a very small series, and actually the N wasn't sufficient to make that statement, but it was a recommendation. This was done in Ohio, and then it was followed up in the AP guideline recommendations. So I'm going to talk to you a little bit about what the data is on that. The other case is the 4-year-old who's playing in the playground and falls off the swings, hits her head, has some vomiting, and is now running around playful and active. Maybe she had 3 episodes of vomiting. How many of you would refer her for a cranial CT? All right, so a few. Based again on the vomiting, is that your recommendation? So, folks might call her into the office to evaluate her. Do you think? Yeah, probably would do that. And so we do see lots of these children referred with recommendations from primary care physicians for CT scans or parental requests for CT scans. So we do see that quite frequently. So what are the arguments for the liberal use of CT scan? Well, there's this preventable morbidity and mortality due to unrecognized traumatic brain injury. We all are aware of that. And these new media cases with actresses skiing and having a head injury and not getting initially evaluated and then dying of diffuse axonal injury are scary to people. CT provides some visual information about the skull and the brain, obviously, and preverbal children are very difficult to evaluate. So the 2-year-old is much more difficult to evaluate than perhaps a 13-year-old. And when indicated, the benefit of the CT greatly outweighs the risk. But what is the risk of CT scan? Anybody know? In a 1-year-old, a single cranial CT, attributable lifetime associated cancer mortality risk from that. So the fact that the likelihood that you could get cancer and die from it, attributable to that single CT scan. 1 in, any ideas? 1 in 10, no, that's really high. So it's actually about 1 in 1,000 or 1 in 1,200 for the first year of life. And I'm going to give you a little bit more data of that, on that. So pretty high, and the thinking is that another 2 or 3 children will get cancer attributable to the single CT scan and not die of it. So there's an associated morbidity associated with it. How about abdominal CT? What do you think, higher or lower? Yeah, about 2 to 3 times higher than cranial CT. How many times more radiation do you think a cranial CT is than a plain chest X-ray? So 300 to 600 times more radiation. And we do, make that decision judiciously, whether or not to get a chest x-ray, for example, in the febrile asthmatic. We don't do that easily. So just some things to think about. So of the 325,000 children evaluated with CT after blunt head trauma, fewer than 10% actually have a finding on CT scan. And this is any finding, even a small bleed or a small ditzel on CT scan. Clinically important traumatic brain injury is much lower, and I'll talk to you a little bit about the definition for that. The drawbacks of the CT include transporting children outside of the emergency department, pharmacological sedation, and the costs and the charges families see with the reading of a neuroradiologist are up to $3,000. And the most important theoretical risk is this lethal malignancy from CT across all comers, all ages, 1 in 5,000, but much higher in the infant group. And there's substantial variation in the evaluation of children with minor blunt head trauma. And so pediatric blunt head trauma and its evaluation has become a very high priority for the American Academy of Pediatrics, the Institute of Medicine, and Emergency Medical Services for Children. And, something to think about. So where do these radiation risks come from? How many of you have seen the Brenner article from 2001? Anybody here familiar with that article? So in 2001, Brenner and his colleagues at Columbia University in New York came up with some theoretical risks. And they extrapolated because CT scans only have been around for about 30 years. So we really can't do longitudinal studies to look at the effect of radiation and risk of cancer mortality. So they extrapolated from children on the borders of Hiroshima and Nagasaki and some other unnatural, unfortunately, experiments. So they found that the risk was about 1 per 2,000, and it's actually closer to 1 to 1,500 or 1 to 1,200 head CT scans for infants younger than a year of age, and 1 per 5,000 for 10-year-olds. And this is attributable cancer mortality risk. Age and size-based radiation reduction efforts are ongoing, but we found there's a lot of variation. So places are still using adult radiation doses to scan children, and that is still the majority of emergency departments and radiation centers, radiology centers around the country. And so there are about 2.7 million total pediatric CTs annually. So that's pretty high, close to 3 million CT scans annually. It's a pretty high number. So this information has been out since 2000. This is some media clips from USA Today, from CBS News, and a more recent one from Newsweek. Basically, the FDA issued a warning to pediatricians and neurologists, use CT scans judiciously. They're dangerous since Brenner's study came out. And the last one from Newsweek is a very recent one from 2010, where they talk about rationing and the fear that judicious CT use or developing clinical decision rules would lead to some kind of rationing. And I still frequently will walk into a patient room and hear a resident or a medical student or even a faculty physician tell families when they ask them, is there a risk associated with this scan? And they'll say no. And that was our teaching. That was my teaching in medical school. How many of you, we really thought the risks, the benefits far outweighed the risks, and perhaps that's not always the case. So we went to the Pediatric Emergency Care Applied Research Network and we said, hey, this is a problem. We've known this since 2001 and perhaps earlier published studies in 1999, and we're not able to reach our colleagues. We actually have seen an increase in CT rates in the United States in children. There's been up to a 30% increase in this country in CT use in the last 20 years. So we wanted to see how can we get the word out, and one was to create a study. So the Pediatric Emergency Care Applied Research Network is funded by HHS, HRSA, the Maternal Child Health Bureau, and EMSC, and it's created a research infrastructure for 25 centers around the country. And Children's National is part of this, and Jim Chamberlain at Children's National is our PI. And we decided to undertake an enrollment of children and see, do elements like, or signs and symptoms like vomiting, like loss of consciousness, actually increase your risk for having an intracranial injury after traumatic brain injury? And our goal was to identify evidence on which to base appropriate ED evaluation of head-injured children. The principal overall objective of the study was to develop a clinical decision rule for use of neuroimaging that identifies children at high risk and those at zero risk of traumatic brain injury needing acute intervention following blunt head trauma. So really the goal is to identify those that have almost no risk and would not require a CT scan. So those patients that you could screen over the phone, perhaps, or see in the office and say, you know, you're okay probably to be watched. You probably don't need to get referred to an ED, or if you do, then the ED doctor would be able to make that assessment. So how did we define traumatic brain injury in need of acute intervention? We didn't look at just any positive CT finding, because as I mentioned, a large proportion of those are not clinically relevant or end up not being clinically relevant. So we defined it as a patient dying from traumatic brain injury, requiring a neurosurgical procedure, requiring endotracheal intubation for the traumatic brain injury for more than 24 hours, or being hospitalized for 2 or more nights for the head injury. And we ended up enrolling over a 2-year period about 44,000 children prospectively. So it's the largest study of its kind. They were less than 18 years of age, and they had blunt head trauma. And they came through the PCAR network emergency departments. And the head CT was obtained at the doctor's discretion. We then did phone follow-up in patients that didn't get CT scan. And we did a morgue review and hospital chart review if we could not contact them by phone for follow-up to look at outcomes. So about 97% of the patients had a Glasgow Coma score of 14 or 15. So they fell into the mild traumatic brain injury group. And CT scans were obtained in about 37% of the patients. They were only positive in about 11.2%, and that's very close to national averages. We see about 10% rate of positive CT scan, and it really varies by level of training and expertise of the clinician. I'll talk to you a little bit about that. And neurosurgery was performed in about 0.5% of the children, and 0.1% actually died from traumatic brain injury. So we developed 2 prediction rules to identify children at very low risk of clinically important traumatic brain injury after blunt head trauma. These rules are published in The Lancet in 2009, and I can actually give the article to Mark to put on the website, so you could take a look at it if you wanted to. The first rule is for children younger than 2, so the preverbal children. And this rule is basically, if you don't have any of the features in this rule, any of these clinical signs or symptoms, then you are at very low risk for intracranial injury and probably very safe to not receive a CT scan and possibly be closely observed. So the rules that take you out of the very low risk group, the items are if you have a Glasgow Coma score less than 15, and this was for children only with a GCS of 14 or 15. So we're saying that the moderate and severe kids we can identify, or you had abnormal mental status, temporal, parietal, or occipital scalp hematoma was present, loss of consciousness over 5 seconds was present, there was a severe mechanism of injury, and severe mechanisms included things like rollover motor vehicle collisions, falls over 20 feet, or a palpable suspected skull fracture, or acting abnormally per the parent. So we put in this parent or subjective feature as well. For children 2 and older, the decision rule was if you had a Glasgow Coma score less than 15 or abnormal mental status, if you had loss of consciousness, this is any loss of consciousness, history of vomiting, a severe mechanism of injury, signs of a basilar skull fracture, or severe headache, you came out of the very low risk criteria group if you had any of these features. So the risk of clinically important traumatic brain injury, if none of the 6 criteria are met, is very low for both age groups. And I think we had about 1 in the under 2 and about 3 missed injuries in the older 2 group. None of them died. And I think none required neurosurgery. So we developed an algorithm based on this rule. Is there a pointer? Basically, so this is the algorithm for children under 2, and it puts kids into 3 risk categories, basically. So the high-risk group are the ones that had the first feature, Glasgow Coma score of 14 or other signs of altered mental status. This was about 14% of the study population, and they had about a 4% risk of a clinically important traumatic brain injury. In these kids, we are recommending a CT scan, and most of us would probably scan them. Now, if you didn't have these features, but you had an occipital or parietal or temporal scalp hematoma, or a history of loss of consciousness for over 5 seconds, or the severe mechanism of injury, or weren't acting abnormally per your parent, the other features in the rule, then we were recommending observation versus CT scan. And it really depended on the reliability of the parents, how experienced you were, what the time was from injury, and if they had multiple versus isolated findings, and if the symptoms worsened after emergency department observation or from the time of injury. And then there's about 53% of the population who had none of these signs or symptoms, and CT was not recommended, would not be recommended. So our estimate is that overall, looking at the study and practice, we would decrease about 30% of unnecessary CT scans applying this rule. The rule in children over 2 is very similar for the high-risk category, except it includes signs of a basilar skull fracture, and the CT not recommended if you didn't have any of the items of the rule was close to 60% of the population in this group. So we wanted to see, so how does this vary from current practice? Maybe we're already very good at predicting who's going to have a bleed in the head. What do you think? Are we very good at predicting who's going to have a clinically important traumatic brain injury? So we're not very good, but we're practicing with a very broad net. So what we did is we did a study to look at our practice versus our suspicion and compare it to this decision rule. So we wanted to compare the test characteristics of our suspicion as clinicians, and we did this prospectively. It was a sub-analysis from our validation set to identify children with minor blunt head trauma with clinically important traumatic brain injury. And then we wanted to see why we were getting the CT scans when we thought there was a very, very low risk of a clinically important brain injury. And we looked at all kinds of variables, and we actually found that even when our suspicion of clinically important traumatic brain injury was less than 1%, we were getting CT scans in about 28% of the patients, so close to 30%, so close to 1/3 of those patients were actually going on to get CT scan. Cindy, why do you think people get CT scans in those settings? Makes you feel better. So you're risk averse, maybe? You're not so worried about the patient. You're like, maybe the family can sleep, and so that's one reason. Anybody else other reasons? Muriel? Parents, so the parents might request it, although we're seeing a big trend moving away from that. Parents are actually more concerned about the scan now. They're asking more questions about the scan than they were previously. Anybody else? Legal, so medical legal risk. So fear of missed injuries, similar to what Cindy talked about. What were your thoughts? Legal as well? Okay, all right. And then we had primary care physician request or recommendation. So over the phone is also a reason. So prediction rules for clinically important traumatic brain injury in children less than 2 and those 2 and older had a greater sensitivity than clinician suspicion, but a lower specificity. And despite this suspicion of clinically important traumatic brain injury of less than 1%, clinicians frequently still went on to get CT scans. And we also found that about 20% of the neurosurgeries in our study population were associated with a clinician's suspicion for clinically important traumatic brain injury of less than 1%. So if we'd acted based on our suspicion alone, which we're not acting on, we would have missed a lot of injuries. But hopefully this rule will help us decrease unnecessary CT scans while avoiding missing clinically important injuries. And so people have asked, what's the association of traumatic brain injury in children after blunt head trauma with degree of isolated headache or isolated vomiting, which was one of the comments made here. In common practice, people get a CT scan just because of vomiting. And we wanted to see are isolated vomiting or isolated headache associated with traumatic brain injury on CT or clinically important traumatic brain injury. And of the close to 43,000 children with isolated vomiting or isolated headache from our group, only 1 required neurosurgery. And for children with isolated vomiting and isolated headache after blunt head trauma, the risk of traumatic brain injury on CT is low. Obviously, if you have combined symptoms, then it could be higher. And we're recommending that doctors individualize the use of CT scan in these cases. So how about isolated loss of consciousness? We know that traumatic brain injury occurs more often in children with loss of consciousness than those without a history of loss of consciousness. But again, for children with isolated loss of consciousness, the risk of traumatic brain injury on CT is small. In other words, you're examining them now, and they have a fully normal neurologic exam, well-appearing, a Glasgow Coma score of 15, no vomiting, no severe headache, so no other symptoms. And loss of consciousness, again, should be considered in conjunction with other signs and symptoms. That's really what the algorithm puts into the medium risk group. And so practice pattern variation, is there an association with physician training on CT scan and rates of positive CT scan? And we actually found, since I'm a peds EM physician, you can guess what the results are going to be here. So the rate of positive CT scan was higher, about 6% if you were peds EM trained, versus about 4% if you were EM only, and peds and EM was much lower. So if you were a pediatrician and then an EM doc and had probably a little less experience with taking care only of or primarily of children with TBI, you were less likely to have a positive scan at about 3%. So how about sedation? How many of you worry about sedation when you're ordering a CT scan? So you worry about the risk of sedation. So we did a review because we had this big data set. And we noticed that throughout the country, multiple agents of varying effectiveness were used. And the complications of sedation, except failed sedation, were actually very rare. We had about a 6.3% complication rate. The most common complication was vomiting. We did not have any serious adverse events, and vomiting only occurred with chloral hydrate. But I do have to remind you that these are primarily pediatric emergency departments around the country. There are a few community hospitals, and there are a few smaller pediatric EDs within general EDs also. And I think 1 or 2 general EDs that also see children. How about basilar skull fracture? So about 1% of the children with blunt head trauma actually have a basilar skull fracture. And we found that trauma CT is actually insensitive for identifying a basilar skull fracture. And both physical exam and a CT scan are needed to identify children with a basilar skull fracture. And we also found that patients with an isolated basilar skull fracture on CT, a Glasgow Coma score of 15, and a normal neurologic exam are actually at very low risk of acute adverse outcomes, and they could be candidates for ED discharge. Obviously, if you're seeing them in the office setting, probably going to do very well. So basically, we have all these children with head trauma presenting to our practices, calling us. And I know Jerry talked to you in a lot of detail about the acute concussion evaluation. And the majority, if they are scanned, will have a negative CT scan. If they're not scanned, we're just going to recommend follow-up with a primary care physician, and they're coming to your office. And so the question is to what to do with them. And so we did another study looking at what tools are available to physicians, to emergency providers, and we assessed whether or not people were familiar with the acute concussion evaluation. Before Jerry's talk today, how many of you in the room had been familiar with this tool? So have you used it in your practice? You have. So a few have used it. And we surveyed 22 emergency providers, and we found that only 1 had used this or been familiar with it in their practice. And so people are still not using it. Again, a tool that's been around for close to 7, 8 years, and still we're not familiar with it. And so the CDC funded us, along with Jerry, to modify this for use in the emergency department. And we found that emergency providers are actually very interested in using this tool, and that they would like both the acute concussion evaluation in their practice to screen patients with concussive symptoms, and its care plan available to them. Most facilities actually have standardized discharge instructions, and you're probably getting those in your practice coming from EDs. How many of you like them? Any good? Have you seen them? How many of you think they're kind of iffy? No? So we actually reviewed them, and a lot of them are very, very vague, similar to the recommendations we make. It basically says if you have a prolonged headache, return to your primary care physician, immediately, and this is on a Friday. And the families will call their doctor, and sometimes the doctor will say, well, go back to the ED. They come back to the ED, and they end up getting a second cranial CT. And that's the management. And so we really are trying to change this practice. And most docs, about 80%, thought that the current forms that they had were unsatisfactory and needed significant modification. So overall, we know there's a lack of recognition and use among emergency providers of tools for screening and follow-up of children with mild traumatic brain injury. And we know that the ED implementation and acute care implementation of validated tools for diagnosing and managing mild traumatic brain injury in children, such as the acute concussion evaluation and its associated care plan, could improve early identification of mild traumatic brain injury or concussion, decrease practice pattern variation, and disseminate information to primary care physicians and school nurses. I'm not really going to go over this. We modified the ACE tool that Jerry showed you initially with an ED version description, which is a little bit briefer. And basically, We are enrolling these patients currently, and what happens is they come with similar things that Jerry talked about. They get a ED care plan, discharge instructions, that's also faxed to your offices. And the next step, and they're supposed to carry a copy into the school with them as well. And the next step is really to see how well this is getting, both to the primary care physicians and the schools, to help manage their outpatient care. It takes about 5 minutes to complete, and it's a good tool also for the acute setting if you're on the phone trying to evaluate someone even. I'm actually going to go through these because I know Jerry spoke very in detail about them. Basically, the goal is to define injury characteristics, assess for symptoms, and identify risk factors for prolonged recovery, and establish the diagnosis, and then plan a follow-up action or referral. And these are items Jerry talked about, the signs and symptoms you can check off. It takes about 3 to 5 minutes to complete. I can do it in 2 minutes. And contains all the common signs and symptoms that are associated, and asks about some risk factors that have been linked to longer periods of recovery, such as prior concussions and prior diagnosis of migraine or chronic headaches. And then once the concussion diagnosis is established, or there's a suspicion of it, they get their care plan. And we have the doctor fill this out, and it's going into our clinical practice as well. So it won't just be a research tool. The study's going to end in about a month, and we're going to continue this with our discharge instructions that are faxed to your offices then for patients that are seen. So the goals are to improve post-injury management and connect the family and patient with primary care follow-up, which is where most patients are seen, we found from our study. They are not seen in the neurology or neuropsychology clinic. Most are seen in the primary care physician office. So the keys to recovery, as Jerry mentioned, are resting the brain and getting good sleep, not interfering with physiologic recovery, and avoiding activities that produce symptoms, and not overexerting the body or brain. And when to return to regular life activities, the recommendation is to return as soon as it's safe, return gradually, and to use the symptoms and neurocognitive function as a guide. If the symptoms don't worsen, the child can continue the activity. If the symptoms worsen, it's recommended, obviously, to stop the activity. And again, how much can a student do? It depends on the neurocognitive and symptom pattern. And the most common question we get in the ED from athletes who have had head injury, whether or not they are CT scanned, is, what do you think it is? When can I go back? I'm sure it's the same for you too, which is a hairy question. And this is just a little bit more on concussion discharge instructions. I know Jerry talked to you about it. And we have a section on when to seek care urgently. Again, it's for the patient that perhaps did not get a CT scan, and we're looking at high-risk variables that might identify a progressing bleed, an epidural or subdural bleed that could occur in the next couple of hours. Again, for concussion, rest is the key, and we recommend a course of managed exertion, and symptoms are the child's guide. And then we have this form that goes back to the school as well. We haven't been able yet to establish a process to, either in the District of Columbia or Maryland, to be able to fax these to the school, but that's our next study. So if you have any ideas, I'd love to hear them about how to do that successfully. And so we know kids should go back when they're no longer symptomatic, and their neurocognitive performance, if they're tested, is back to baseline. And you can find all this information on the Heads Up Brain Injury in Your Practice that Jerry talked about with the physician's toolkit. It'll be updated with our Acute Concussion Evaluation Emergency Department form as well. So what are the future directions? Is to develop a mild traumatic brain injury diagnosis and management pathway that we can disseminate nationally. So our goal is to decrease unnecessary CT use with this, but also to identify those kids who have concussion and need outpatient follow-up instead of letting them just have lost to follow-up and no evaluation. And then we want to disseminate our tool, the Acute Concussion Evaluation ED version and its care plan, and then assess the effectiveness of these tools in early recognition and management of pediatric mild traumatic brain injury. And our final but most important goal is actually to improve communication with you, the primary care physicians, schools and families regarding management of children with mild traumatic brain injury and concussion. So this is me ski jumping. And, you know, our goal really is to improve the care of kids with mild traumatic brain injury, and we are missing so many of these children, and we are providing care that is very outdated, you know, with our CT scans, exposing them to unnecessary radiation, not diagnosing concussion or kids at high risk for concussion, not arranging for follow-up, not arranging for this cognitive management, and we've had this data for years. And it's kind of frustrating, but also hopeful that we're going to be able to, you know, improve this from the lessons from the last decade with our care in the next decade. So I encourage your partnership in this process. Thank you.
We have time for a couple questions.
Yes. Could you mind grabbing the mic?
Yeah.
Is there a time when the history of past traumatic brain injury can jeopardize sports clearance?
Sports
Clearance.
You know, if they're still symptomatic, obviously, or if they had a severe injury, but if the symptoms have resolved completely at rest and exertion, the thinking is both for second impact syndrome and for concussion or second concussion or post-concussive syndrome, that the likelihood will be very low. So they're pretty safe if they're totally symptom-free at rest and exertion, is the thinking. Yes, with a history of past. So there's no specific time that that would affect you if you're completely symptomatic, asymptomatic now when you're being seen. Yes. Do you mind going to the mic? Thank you.
One of the things we practice out in kind of a rural community where there's the nearest neurosurgeon is here, about 2 states away. So a lot of times we get the child with mild concussion, doing fine, might be slightly altered, and rather than want to observe them in the ER, they admit them for observation overnight. And you know, this is a great concern to us because the only thing we're going to do on the floor is watch the child die. So, you know, the question is, what do we do with these kids? I mean, you know, I thought the previous criteria was to observe them in the ER for 4 hours, 6 hours, 8 hours, and the risk went down. But, you know, this is an ongoing battle for us. So.
Yeah, it definitely does go down. We're actually doing a secondary analysis. We just presented at SAEM. Basically, the children that were observed were all fine. None of them had any significant injuries. If they fell into the low-risk category, even the intermediate-risk children did not have any significant neurosurgery required. We're talking about mild traumatic brain injury.
Right.
So the ones that present with a GCS of 14 or 15 that you might not scan. But the secondary analysis is going to look at exact timing of observation, because it's a little more murky, you know, from the time of injury to the time of presentation to the ED or the time of decision making. So the thinking, you know, for epidural bleeds is about, you know, 6 to 12 hours after. So, you know, but if a child is running around in the ED, playful, happy, 4 hours out of an injury, doesn't meet any of these high-risk criteria, or any of the criteria of either rule, I think they're very safe to basically say, we've observed and you can go home. So very, very unlikely that, you know, these were 44,000 kids that we looked at, and about 43,000 of them had mild TBI.
Yeah, this is a cause of bloody wars out in the boondocks, so thanks.
But we'll have that exact number for you soon. Yes, sir.
One last question.
In your screening, when you have no symptoms, what do you code the ICD-9 code? Do you give it? You're not going to call them traumatic brain injury.
No.
So what code do you give them?
Well, you could do blunt trauma to the head, or if they have no symptoms at all. It depends on what else is going on. You know, if it was it could be a strain. You know, if a ball hit their head, a muscular strain. It could be a contusion. If there's a hematoma of the forehead, if there's a laceration. Obviously, it would be a laceration without the TBI diagnosis. All right. Thank you very much.